So this is Bartter syndrome. And Bartter syndrome is a defect in what channel? What is Bartter syndrome? All right, so Bartter syndrome is actually a defect in your triple pump, your sodium, potassium, chloride, sorry, it's not, so the triple pump in your ascending loop of Henle, chloride transporter, right? It's at the thick ascending loop of Henle, that is what is not working or it's defective, right? So you lose your NaCl. When you lose that pump is actually going to reabsorb all of those. It's going to reabsorb sodium, potassium, calcium, and the potential that it generates after reabsorbing all of these things is going to cause even reabsorption of calcium and even magnesium. So in these patients, all these electrolytes goes down. So they have loss of NaCl. When you lose NaCl, that's called natriuresis. When you lose sodium and chloride, water is going to follow. Patient is going to have hypotension or maybe normal if the free water resorption is working well. So what happens is that their volume goes down, their blood pressure maybe go down or may not go down. So the blood pressure is going to remain below normal. Whereas sodium, when you lose too much of sodium, it's going to go to macula densa. It's going to activate your juxtaglomerular apparatus, saying that you need to secrete renin, right? So it's going to increase your renin. It's going to increase your aldosterone, activating your RAS system. So yes, you're right. It causes hyperreninемia. It causes hyperaldosteronism as well. And calciuria, as I said, yes, you are right. It's about losing the calcium and magnesium as well, right? So of course, when you lose calcium, patients are going to have constipation like this patient had, polyuria, polydipsia. These are all hypocalcemia symptoms as well. Patients are going to crave for salt-rich food. Why? Because you have hyperaldosteronism and you're losing sodium, you're losing salt, you're losing NaCl. So they're going to crave for it, right? Also, the treatment is basically that you give them salt-rich food. You also give them sodium and potassium supplements. And also you can give them aldosterone antagonists, so that aldosterone doesn't cause too much of potassium excretion, right? Because that will cause hypokalemia and it can even precipitate a cardiac arrhythmia in these patients. Examples of aldosterone antagonists, right? Spironolactone, right? Eplerenone. These all are aldosterone antagonists. So you can use them as well just to prevent hypokalemia in these patients, right? Another thing to note with Bartter syndrome, do you know the drug that has a similar mechanism as what is defective in Bartter syndrome? Yes, loop diuretics, right? So loop diuretics such as furosemide, right? So they are going to present in the same way. So you may want to rule out furosemide abuse, or you can say diuretic abuse in these patients. Other options, renal artery stenosis. Renal artery stenosis is going to present with high renin, high aldosterone, I agree, but it will have hypertension. Patients will have high blood pressure, which this patient does not have. So you can rule that one out. Again, with primary hyperaldosteronism, they will have hypertension. So that's again ruling that out. Pheochromocytoma is the adrenal medulla tumor, right? It secretes epinephrine, norepinephrine, and patients have classic presentation of episodic or intermittent headache, palpitations, high blood pressure, and things like that. So pheochromocytoma, it can be unilateral, it can be bilateral. You can say, how do you diagnose pheochromocytoma? You can measure urine metabolites of these, right? So those are your VMAs, vanillin mandelic acid, and those weird stuff, metanephrines and all that. So you can measure them in the urine and diagnose pheochromocytoma. Do you know what's the treatment? What do you give first, and why would you give? So you give them phenoxybenzamine. Why? Because it's going to block the alpha receptors first. You never want to give them beta blockers first, because it's going to cause hypertension, because your alpha blockade is, like your alpha receptors are basically open for epinephrine and norepinephrine. So if you block beta receptors, it's actually going to cause hypertensive emergency in these patients. So you give them pheochromocytoma, then you can give them beta blockers, and then you surgically remove it. Gitelman is basically DCT, your sodium chloride transporter, and your DCT is what is defective. It does cause low calcium and magnesium as well, but it will have like a, how would I put it? It doesn't cause urine calcium loss that much to even cause, like hypocalcemia. It does not have these severe presentation types, and it's only sodium and chloride being lost. So potassium is a little bit okay in that case as well.
Thanks for watching. Please give a thumbs up and subscribe for more.